and thank you for the kind introduction to our thematic. And we can just skip over from the last talk to just give a focus on the immune-mediated diseases as well. So our title is the lipidome as component of MultiOmics analysis in the deep characterization of the immune-mediated diseases. Just to go back a little bit to the overview and the background of immune-mediated diseases. So we have here a heterogeneous group of diseases with its origin in dysregulation of the immune system, of which 8% of the population suffers from. So we have a high medical need of early diagnosis and to find the best therapeutic strategies. In the best part, it would be individualized or personalized therapeutic options. As you can see here in the picture beyond, there are many manifestations, including the musculoskeletal system, the cardio system, the pulmonary system, the gastrointestinal system, as you heard before, with the IBD problems, and the central nervous system. But the problem of all is that we cannot categorize these diseases in these organ classes, because it can depend on the indication and the disease that all of those systems are included or involved in one of the immune-mediated diseases states. This is a special form of medicine here, because as you all know, in our health system, we have the problem that only organ systems are targeted within the indications, but we have here a problem of all organ systems. And so we have to find here solutions for diagnosis and therapy. And this underlines this hypothesis that all of these diseases, and you heard them before, Crohn's disease, ulcerative colitis, rheumatoid arthritis, psoriatic arthritis, are somehow affecting autoimmune and autoinflammatory processes. And in which kind they are affecting these depends on how much of the immune system is involved, and if there are antibodies that are detectable to just underline this. To give an example of psoriatic arthritis, we have here a classical disease which starts with a risk population with patients that have psoriasis of the skin, and 30% of those patients will develop psoriatic arthritis in the long term of their disease, but we do not know which of the patients will be this risk collective. And here is the hypothesis of this transition from psoriasis to psoriatic arthritis, with different hints that must happen to just develop PsA. But of course, we see patients in a late status of PsA with already clinical phenotypes, but it would be the best to see them in a much earlier state of the disease, somehow here in the subclinical PsA group or in the preclinical PsA, or at the best, just treat the patients that are on risk. So to identify these 30% of the patients. And so it's a deep and medical need to phenotype those patients, to have the opportunity to get them early in the medical care and to treat them right, because here it's the best example. The treatments of psoriasis and psoriatic arthritis are somehow really the same. So we have to depress the immune system in specific ways. And we have here the opportunity, if we treat psoriasis patients right, to prevent development of PsA. But this is a single example for those immune-mediated diseases and the hypothesis of our research platform. For the key elements of our research, we have the transdisciplinary care of those patients with these different diseases. We have a team of rheumatologists, gastroenterologists, dermatologists, and as well psychiatrics who work together to have the opportunity with deep phenotyping to identify pattern for early diagnosis, detection of manifestations of IMDs, and for identification of the best treatment choice. In the next picture, it's just an example how we think this could be possible, because as you heard before, for the IBDs, there is as well the pattern that IBD can be a part of spondyloarthritis or the indication of spondyloarthritis, for which as well psoriasis and psoriatic arthritis play a role. And so we try here to put it to the transdisciplinary approach to identify deep clinical phenotypes that can predict if they are responsive for the treatments with different biologics, or are responsible for the detection of early diagnosis of these diseases. So we can put this into clusters that are independent from organ classes, that put them into the care of different indicational experts, and to individualize and personalize the treatments so that we have the best care for those patients. And how we try to make this, I hand over to my colleague, as he will take over the part of the analytical sides of this platform.
Thank you very much. So first of all, I would also like to thank the organizers for inviting us to this symposium, giving us a chance to tell you about the projects we are currently realizing at the Fraunhofer Institute in Frankfurt. And the first part of our talk gave you an introduction into the clinical field of immune-mediated diseases and why the medical need for new diagnostic tools is so high. But now let's talk a little bit about the lipidomics part as part of a multi-omics analysis, and why it can be a valuable way to establish new therapeutic strategies in the field of IMDs. First of all, let's have a look into our overall approach. The first part was already described by Michaela. To sum it up, we have a very close cooperation with the clinicians from the rheumatology and the dermatology and the gastroenterology. And these clinicians provide us with patient samples, but also with all the background information about the patient we need for our multi-omics analysis. Besides lipidomics, further omics technologies like metabolomics for polar metabolites, proteomics, and cytomics will be applied for every patient sample, generating a huge data set, making biomarker identification possible. Finally, data will be evaluated using machine learning approaches, resulting in the creation of multidimensional patient profiles and immunological maps. The main focus of my group is about the lipidomics part in this multi-omics approach, and our main field of expertise is the targeted LC-MS/MS analytics for quantification of lipid mediators in different biological matrices. As probably not all of you are familiar with this term, just a very short explanation. Lipid mediators are very low concentrated lipids, highly relevant signaling molecules, and implicated in a variety of physiological and pathological processes. And this figure illustrates the spectrum of analytes which are analyzed within our group. We are combining the targeted approach for lipid mediators like sphingolipids, marked in green, endocannabinoids marked in yellow, lysophosphatidic acids marked in purple, and eicosanoids marked in red, with a non-targeted approach for more abundant lipids, which are marked in blue in this figure. This results in a very complex screening, as several LC-MS methods have to be used for every sample. However, using one screening method for lipid mediators isn't possible, as the concentrations are very low and highly selective and sensitive methods have to be used. The reason for such a complex strategy can be found in the numerous studies applying lipidomics analysis in the field of IMDs. When searching for relevant markers for IMDs, as for example in the field of rheumatology, you find publication linking eicosanoids to this field. For gastroenterology, studies indicate that sphingolipids and endocannabinoids are of high relevance. In case of dermatology, the group of glycerophospholipids and SPMs are discussed as relevant compounds. And in the field of psychiatry, a recent publication indicated eicosanoids as possible markers. As you can imagine, this is not a complete list of studies and findings, but a short summary to give you an idea that a lot of work has been done in this field. And this makes lipidomics a reasonable technique to be used for biomarkers or for biomarker search in IMDs. However, none of these findings was yet transferred into the clinics, as studies validating these findings in a clinical setting are missing. And studies might be, one explanation might be that these studies are very complex. And one of the main hurdles comes with the blood sampling. That's our experience. And there are a lot of pre-analytical challenges. and therefore we took a closer look at these pre-analytical factors influencing the analyte concentrations. And for example, this is of extremely high importance for endocannabinoids, which are very prone to ex vivo formation, and a strict pre-analytical protocol is necessary to determine them quantitatively in any biological methods. In our study, we focus on blood samples and prefer to use human plasma. In one of our experiments, we analyzed different lipids and lipid mediators in whole blood and plasma samples handled differently in the pre-analytical phase, as illustrated in this figure. And here we compared sampling tubes containing K3-EDTA, as well as sodium fluoride citrate, and stored whole blood as well as plasma for different periods of time under cooled conditions, as well as at room temperature. On the right side, you can see the results for two groups of analytes, namely endocannabinoids and lysophosphatidic acids. And especially the endocannabinoids change rapidly while pre-analytical sample handling. And it's especially a problem of storing the whole blood sample in K3-EDTA. So we repeated the experiments for a closer look into the group of endocannabinoids in the K3-EDTA samples. And as you can see from the graphs, for example, for 2Ag, it's in particular a problem of storing whole blood. Even permanent cooling cannot prevent a significant increase of analyte concentrations. And the endocannabinoids are one of the most vulnerable groups, I have to admit. But their concentration changes due to pre-analytical sample handling are very, very intensive. But also other lipids like the before mentioned lysophosphatidic acids or sphingolipids like S1P or oxalipins like 12-FET are very prone to improper pre-analytical sample handling. So if you want to analyze any of these compounds, standardizing pre-analytics is of utmost importance to prevent measuring artifacts. Another critical point we have to discuss very often with the cooperation partners and clinicians is why we couldn't use serum samples for our analysis, and a lot of studies are performed using serum samples. It is known, at least for the lipid mediators, that serum and plasma are not comparable for several compounds, and our experiments confirm this finding, as can be seen in this figure, for the analysis of endocannabinoids. The concentrations in serum are significantly higher than in plasma, and one part of the explanation might be that serum has to be stored for at least 20 minutes at room temperature, and permanent cooling or rapid processing isn't an option. So these higher concentrations might be an artifact caused by storing whole blood at room temperature, favoring ex vivo formation. Therefore, we recommend to use plasma instead of serum and to apply the strict pre-analytical protocol you can see on the next slide. So first of all, we try to collect the samples between 8 and 10 in the morning to lower the effect of circadian rhythm. And when the sample is taken, it is very important to cool it immediately after the sampling. As the clinician's primary task is patient treatment, it has proven to be useful to have a second person available taking care of the sample. Following the blood collection, the sample has to be transferred to the lab under permanently cooled conditions and centrifuged within 20 minutes after the blood collection. Thereafter, the plasma has to be separated immediately from the cells, homogenized within a greater tube, and separated into low volume aliquots. Finally, the aliquots have to be stored at below -7°C, and all of this procedure has to be completed within 1 hour after sample collection. Unfortunately, further factors can influence the analyte concentration and have to be considered when planning a study, or at least when evaluating study results. I have already mentioned the circadian rhythm, resulting in time-dependent changes of the analyte concentrations, and other factors, to name just a few, are fat status, sex of the participant, as well as known diseases and metabolic status. And besides pre-analytical factors, there are also analytical factors having negative impact on the data quality. This is especially true for lipid mediators, as occurrence of isobars and isomers is very common. And isomerism can also proceed while the analytical phase, resulting in changed analyte concentration. These pre-analytical and analytical challenges are a main reason why I'm a big fan of targeted approaches, as detailed knowledge on each analyte, or at least group of analytes, is necessary to prevent determination of incorrect data. As our pre-analytical protocol is very demanding, we are not analyzing samples from biobanks, but started our own sampling, including patients with different IMDs, as well as a healthy control group. And we have just finished a very small pilot study looking into the cardiovascular risk of IMD patients. And in addition to our own methods for lipids and lipid mediators, we also applied the MXP Quant kit provided by Biocrates within the study and evaluated the data in combination with results from our targeted LC-MS methods. Furthermore, proteomics and cytomics analysis have already been performed, but have not yet been included in the data evaluation. And the main objective of this pilot study was not to find a final biomarker, but to prove whether this pre-analytical protocol is feasible and the quality of the samples is sufficient. However, we have analyzed the data produced in the study, and this figure displays a preliminary data evaluation showing that it is possible to separate patients with and without cardiovascular risk. As the limitations of this study are very clear to us, we will explore that in more detail when analyzing a greater number of patient samples, as well as samples from a healthy control group, as such a group wasn't included in this first pilot study. A second project I would like to show to you is our COVID project called CoV-Immune, comparing COVID patients and the healthy control group. The patients had moderate or severe symptoms, but all of them were treated in the hospital in Frankfurt. And like for the previous project, I cannot show you a final data evaluation for the MultiOmics approach, but a preliminary evaluation for the lipidomics part. And this first evaluation, a supervised multivariate model was built to identify potential interesting metabolites. And as you can see in the figure on the left, the clear separation was achieved mainly based on LPCs and ESAPC species. That's where we are now. We have conducted two smaller pilot studies, and we're very satisfied with the results. To sum our talks up, you have seen the high medical need in the research on new therapeutic strategies for IMDs, that MultiOmics in combination with clinical and patient-oriented data could prove a promising approach towards identification of biomarkers, that a translation into the clinics is a challenging task, especially because of the pre-analytical hurdles. But taking the positive results from our pilot studies into account, we are very optimistic that translation into the clinics is possible and that we might be able to find some biomarkers within the next time. And with that, I would like to thank for your attention and would be happy to answer your questions.